Hey guys, happy Easter people. We are going to get on with a denture extravaganza. We're going to get Matt on, Matt Brennand Ropert. We're going to chat all about denture retained implants. He's on.
Hey, hi Ropert, how you doing?
I'm good, you well?
Good, I'm well, thanks. How's your day?
Yeah, not too bad. Nice little
Good.
long weekend, 5 days of it.
Oh, that's not too shabby. Not too shabby at all. I think I work 5 days a week. It's definitely not the way forwards. I think it has to be about the 4 day week or less. That's the dream, surely. Yeah, I don't know whether, I've got you
Trying to
back.
get my head but they're not working.
All right, okay, yeah. If you hear some really strange noises coming through the window, when the wind comes from a certain direction through my flat, apparently whoever did the roof has not done a good job, and there's like the membrane that sticks out, so it's like blowing through grass. So if you hear this sort of weird farting noise, it's not me, it's the window.
Over
Yeah.
an Easter weekend.
Oh my God, it's totally. Although I saw loads of people eating their Easter eggs. Isn't it? Are you meant to have Easter eggs on? Is it Monday you're meant to have Easter eggs?
I thought it was
Or
yesterday.
is it Sunday? Oh, okay. So that's my parents holding me off the Easter eggs for years and saying,
there
no,
you
it's
go.
Monday, it's Monday.
You in Edinburgh or Glasgow?
Edinburgh. Edinburgh this weekend.
Had the cold, the really cold. We had snow this morning down here. It was bizarre.
Oh, did you?
Mm.
Yeah, I think we've just missed it. I think it's been, but it has definitely, it's definitely been snowing around the place for sure. It's absolutely Baltic. Like, it's properly cold, especially after last week, which was lovely.
Yeah, we had the sun eventually, which was all right, but it wasn't ideal this morning. First thing.
But where are you again? Are you Fulham?
Fulham.
Yeah, snow in Fulham. That doesn't happen.
Yeah.
That's the sort of thing that you bet on at Christmas and never win.
Well, on Edinburgh v Glasgow, do you want to just give everyone a little intro about yourself and jump
Yes.
in, won't we?
Yeah, cool. So I am a consultant in the Glasgow Dental Hospital and Restorative Dentistry. I've been up in Scotland now for just over 10 years. I moved up to do mono-spec training first. As a registrar, and I did that for 3 years, and then I did 4 years restorative top up. I say top up, so just a quick top up. So 7 years specialist training full time. And I've been over in Glasgow for 4 years now, but I've been living in Edinburgh and commuting between the two because I work in a specialist refer. It's the only way. No, I have actually just moved to Glasgow because the commute's horrendous.
Yeah.
But I still work in practice in Edinburgh, so I'm still working between the two. And I'm about to start working in a practice in Glasgow as well. So yes, I think I'm spreading myself probably too thin, but I'm dropping time in the hospital to do more of that. Because actually, I really enjoy the hospital, but I love working in practice as well.
How's
So
the side of it been with COVID?
So the hospital has been tough because obviously when all the dental practices shut, the dental hospital became the COVID hub for pretty much the west coast of Scotland, and GGN's Greater Glasgow and Clyde is the biggest health board. So I mean, at one point we had something like 250 phone calls a day for emergencies, and our capacity is now only down to maybe 30 because, as you know, most dental schools are all open clinics.
Yeah.
And obviously you can't have open clinics, so it's entirely limited by the number of chairs. And then obviously as people were working out fallow times, I mean, the dental hospital is essentially a closed box. And so there are 5-hour fallow times on some of the rooms. So they were trying to work out what the ventilation was, what we could and couldn't do. And we were changing, I mean, we were right at the sharp end of working out what was happening with aerosol procedures, getting used to different protocols. So it was hard work. It was really hard work, actually. It was quite draining, even though there was some sort of time off in between. But we were essentially on a rota. It's just one big emergency rota. But it's quite surreal seeing caries for the first time, because most of my patients, they don't come in with caries because they're generally well maintained by their dentists, or if it's tertiary care, it doesn't happen. So it's quite surreal.
You have to
But
dust off those extirpation skills.
Oh, I love it. Well, I do endo anyway, so I do quite a lot of endo. In the hospital, I do endo and surgical perio and hypodontia mostly, and then in practice, it's all pros and implant work. So actually, yeah, but de novo endo, you realise how great a de novo endo is, rather than trying to get around something that's severely ledged or has been retreated 3 times or has fractured instruments. So actually, it was really quite enjoyable. Sometimes it was quite nice, for sure.
And obviously, you do a fair bit of work with ITI now.
Yes,
which is how we've come into contact. So what's your role again within, obviously you're on our young committee.
I'm on the UK and Ireland Young ITI Committee. And I'm also on the International Young ITI Committee, which it's definitely going through quite an exciting time because, you know, we've now got you guys on board as ambassadors, which is fantastic. And I think we had been really struggling to generate more content than we were. We were sort of limited because it was a small group. It was myself, Paul McGannity and Narinda Dalwal. And we were really focused on putting out a few events a year and trying to spread the word. But actually, we were not achieving our goals, which was just engagement and just really reaching out. Because the ITI is over 40 years old. It has the most amazing... it's got the ITI Online Academy. It's got great study clubs. And this, you know, I've never really been one for being indoctrinated or trying to, you know, bring people into a particular fold. But the ITI is an impressive society. But what it's failed to do is it's not really connecting with younger generations. It just doesn't seem that sexy. And you know, and HQ are like, well, what do we need to do to bring more people into the fold? And I think this engagement is key. And I think with you guys on board, we've been able to reach more people. I think there's just more people who are savvy and doing, you know, interesting things and looking at things from different perspectives, or just putting old perspectives, well tested, tried and trusted protocols and techniques out there for everybody actually to see and just make the ITI relevant. Even though it's never not been relevant, bring it into the, you know, into people's sites again.
Yeah, totally. So we had the pros evening last week, which I was lucky enough to be asked to present on, and it went, you know, relatively
it went
well.
smoothly. It went smoothly, apart from the slight hiccup of no guests being able to get in.
Yeah, so sorry, anyone who's watching that wasn't allowed in. We are working on something, aren't we? With we decided if we're going to do a recording or a redo.
Yeah, for sure. I think it's just what happens is we have to go through the ITI Net account, and the problem is the people who run that are employees of the ITI, and so because they weren't there when there's a slight hiccup, there's no one then to actually physically, manually let people in. So that was the hiccup. Whereas people who have already members, they've automatically got a pass straight in through their account. So it's a real shame. It's a real shame. But you know, this is the live follow up. This is the after show. This is where it's at.
Yeah, this is the bit. We just need Emily and John and Lindsay as well. I think I saw Emily skulk on here.
Well, she's put up some great stuff. She's been putting up some great stuff, and I'm sure the people who are speaking have all, you know, are pretty good at posting their content, especially with that thing that you popped up, that guide, Insta guide. That was fantastic. Yeah, really cool, really nice.
It's just you have to think a lot about it though, because you can only use the only pictures you can use are posts that you've done or that you've saved, and it can only be the first picture of the post as well. So I had to really think about. Luckily, I'd used everything already, and I actually thought about that when I did the presentation because I had it in mind before, but it's just too much thinking in my head.
It's basically a lecture in itself, because I mean,
she is. Emily's on.
She's in. Hey, yeah, because after you showed it to us and I had a little look, I was like, oh my god, right, I've got to go through everything and actually download it. I was like, that's for another day. That's definitely not for today.
No, it's
cool.
It's a cool concept.
Oh, it's really cool. Yeah, I think it's great.
So obviously we're going to talk through sort of the follow-up for what cheers Denzel. We're going to talk through sort of follow-up for mine, because we only had 15 minutes. So for those that couldn't make it as guests, I was chatting through denture, all your your reeds going by
Yeah,
the
can
sound
you
of
hear
it.
it? I was just, did you see me put my hand over my mic? It's like, oh God, if it's really bad, I'll have to move into a different room.
No, it's fine. But yeah, so my talk was about optimizing dentures for implants, talking from a pros first perspective. So what we meant from that was um, essentially working with the prosthodontist I work with in my practice at Woodbury House, Nick. He will see the patients, assess them, decide roughly what kind of thing we're doing, and then they come to me to make some dentures, make sure they're happy with them, do the full process as normal as if there aren't going to be any implants. And then we're going to use those to plan the surgery, do guided surgery, and then retrofit. So we're going to talk about everything else apart from that. So assessment-wise, I covered a couple of things in the sort of considerations, I called them. So space considerations, really. Now, I know you do bar, sleeve kind of things more. Nick and I don't really do that. We've done locator stuff. So just give us your idea on why sleeves and bars, locators.
Yes. Well, I've got some nice pictures to show later, actually, for our space discussion. And I've got some pickies that we can show, but for me, locators are fantastic. They're a great way of improving implant retention, and they are helpful when you don't have a lot of space. They're cost effective, but they definitely, if you don't have parallel implants, if they're off, okay, you've got range extenders, that's fine. But I have seen so many cases over time that have come in and they've got locators that, they're off by a reasonable margin. And even with the extended range, you get significant wear to the locator nylon insert itself. But you also start getting the locator, the actual hardware itself starts getting battered and worn. And that's okay if patients have been, it's not really okay, but patients need to be appropriately consented and aware of the upkeep, because there's definitely going to be a fair bit of upkeep over time. And I think those treatment plans make you either really thoughtful and careful about where you put your implants and trying to find ways of paralleling your implants, and otherwise you need to, although I just saw actually Novalock have got an angle correction, but again, it's this, you're trying to close the gate after the horse has bolted a little bit. So if you can try and move away from that situation which gives significant upkeep over time, actually that's where a bar fits in really nicely. And you can put a really nice milled bar in with two perfectly parallel locators, maybe a little rider at the front, and you will get such nice retention with much better wear of the components over time. But like you were saying, it's space, and obviously there's an increased cost to patients. I think, to be fair, if you can get a patient to invest that little bit more for a bar and you have the space to do it, it's an investment that is worth making for sure. And there's a couple of cheats that you can make to a certain degree to get around bar height. But ultimately, you need space. It's like anything in dentistry. You need to have the space for the materials to work to their best.
And what would you say space-wise, roughly? Obviously, I said the thing.
Well, should we do it? Should we do that space? So I've got a little slide, actually. Yeah, let's do it. And I'll stick it up afterwards, because I think it's one of the most important. Let's get this to flick. It's so important, because the problem is, if you get caught out, there's not, apart from going backwards and then providing a locator which you told the patient you didn't want to provide in the first instance. But should we have a poll? What height do people think they need from sort of the gingival margin, or let's say the implant head, the fixture head, all the way up to the incisal tip for a lower? If people fancy sticking some
We've got Minty here, so Minty.
Come on, Minty. No pressure. In millimeters, let's see, or not.
We said sort of 15.
Yeah, for sure. So if we you'll have to forgive this. It's quite basic. This is my level of skill. So let's say we've got some implants here at the fixture level, and then we've got our soft tissue. So we obviously have to be respectful of the let's just call it the peri-implant supracrestal tissue. So if we say we then need height for our abutments, you pop your abutments in, let's call those locators. Minty's in the supermarket. Yeah.
He's in the milk aisle.
So let's put some abutments on. Sorry, I'm having to just check that you guys can still see. I'm not waving my phone around too much. Then you've got your bar, okay? Then let's say you've got some locators on top of your bar. Then you have to have your acrylic in your teeth. So if we work back from there, you need about 3 millimeters, let's say, for your supracrestal attachment around your implant, for your connective tissue and your peri-implant junctional epithelium. Then you need about 3 millimeters minimum for the height of the bar itself. Then you need a couple of millimeters for the actual locator and the housing for the locator. Then you need a couple of millimeters of acrylic, okay, because otherwise you're going to experience problems. And again, we can show some pickies of that. And then let's say you've got 6 to 7 millimeters of the actual tooth itself. So in total, you're probably looking at about 17 millimeters. So 15 would be your absolute minimum, as in you're going to struggle to get away with 15, or you're going to end up with really short teeth. So, you know, when you pop that up and you ask questions in lectures and say, what do people think? You know, people are like, oh, 12, you know, because actually, you know, 12 millimeters, when you start looking at a centimeter, it's massive. I mean, God, half the time we're looking at a millimeter and thinking a millimeter is enormous. So when you start saying, well, you actually need nearly 2 centimeters, that is a lot of space. And you have to be really cognizant of that, because otherwise you're never going to manage to put it in. And also you need to be thinking about where, you know, if you've put your implants in too labial or too lingually, vice versa, okay, we've got angle correction. But again, then your superstructure's out of position. And then you're going to end up with a really bulky bar, or you're never going to get the acrylic around it. And you're going to have, so you might have a technically functional prosthesis with regard to the space that you've created, but actually you've got a prosthesis that the patient can't wear because they can't get the tongue around it, or they can't speak with it. So once again, all of this comes back to, you have to have the prosthesis finished and finalized that you are going to use, or at least have a wax trion that you can create an index from, that you can then use as your surgical guide. Because otherwise, you know, you're scuppered.
Yeah. So for either method, locators or bars, then you if you're still doing that pros driven side of it, you've got that method of planning then either way, and then you can assess it better. So
yeah,
in
absolutely.
terms of that actual planning, all digital, scanning in the prosthesis. Talk us through that process.
Okay, so there's 2 ways. I don't think, like, definitely digital is the way forwards, and I'll show you a couple of pickies of bits and pieces, but I think, you know, from a purely, you can do this purely analog, and I think you should be doing it you should be doing this as a minimum. It's not, I'll stick the implants in, the rest as an afterthought. I think you design your final prosthesis, let me ping the screen round, and then, you know, you can use something like this that has the tooth position in, and then you create cutouts so that at least, okay, this isn't going to parallel your implants, but at least you're going to know the parameters and the space with which you're trying to work in. And then let's say you've got a wax try, something like this. This is really old school. This is from about 8 years ago. But it just shows you, and again, you know, I think you brought this point up, but you shouldn't try and change a patient's occlusal relationship just because you want it to be class 1. You know, you should be respecting the skeletal pattern underneath and then putting the teeth in the right position. So this obviously looks like it's miles out in front, but ultimately that's where it needs to be for this particular patient. But things like this help you visualize and understand where you need to be within that prosthetic space. And I think this is where planning comes in, because I think digital work down the line, let's see, I don't even know if I can get this to work. So this is slightly reversed, but I mean, this is a case that I'm doing at the moment. And you can use STL files. So once you've got your denture, let's say you've got the endpoint there, which is the denture, you scan that and you can superimpose it over the CT scan, and then you get a guide that sits on the soft tissue. But again, that's entirely driven. All of that implant placement is driven by the position of the prosthesis. And then you just simply work back from there.
Yeah, you're producing, to do that, you're producing like radioplasties on, placing them onto the denture as well, aren't you? So you can CT scan.
Oh, yeah. Yeah. So,
And then
Absolutely.
you
So in the
cross-reference that with the
yeah.
iTero Scout Trios or
Yes,
whatever.
yes,
Yeah.
totally. So the key thing that stitches it together are those little ball bearings there, which are composite hemispheres. So they sit in your denture. So I would just use you could use a wax try-in, or you could use an acrylic denture. But as long as that's going in the CT scan with the patient in the position that you want it. So I'd have relined it first to make sure it was super snug fit. And then afterwards, once you scan it to get the STL file, the STL file picks up those hemispheres, and then you can link the two together.
Yeah. And then from that, you're making your surgical guide.
Yeah, exactly. But I think even at the most basic level, I mean, this is a picture of some really straightforward implant planning. But again, it's the implants are digitally planned so that you know where the position is. And you can see those little hoops. So those are using the patient's denture, which was prosthetically within an envelope of tolerance that it was basically a copy denture. So we were quite happy with it. And that actually, a really simple level, is just old bits of foil. So, radiograph lead foil, and you cut them into strips and you fold them over the teeth, so you know where the laterals are, you know where the canines are. But actually, you can see here it projects up onto the palatal surface, and also you can see where you are with regard to your canine position, because otherwise you don't know where you are. So even at a really basic level, you can still use digital planning, even if you don't have an intraoral scanner, for example. The only thing is, you need to make sure again that your denture is sitting in the right position and it's it's nice and stable and secure, because if it's not, things are all over the place.
Yeah. But again, that's the whole point of making the pros driven, doing the pros stuff first.
Everything is pros driven. I think and we've known that for a long time now. Everybody knows that, but it's just making sure that your pros stages are correct, because it's all very well having something pros driven, but if your pros is wrong, crap in, crap out, whatever.
Yeah, and like I sort of brought up on the actual on the evening itself, the benefits of doing that, or understanding those basic principles, is still super important, even if you're never going to make another denture again. But if you want to do implant work and do your all on X, I think it's the fashionable word now, isn't it? But
but you know what?
The planning based on that.
Yeah, for sure. But cosmetic dentistry, any aesthetic work, and is based around the principles of a complete full denture. If you can nail the aesthetics on your full denture, you've nailed aesthetics full stop. So they're directly applicable. And as you can get some of the most beautiful work now, and I think, and it's always an interesting discussion when patients say, oh, is this going to be metal ceramic, is it going to be acrylic, is it? And you can get such beautiful acrylic work that actually sometimes you have to have an amazing technician actually to get such a lifelike result. And the mistake is when you make somebody a really beautiful provisional prosthesis and then you change over and they're like, fortunately so you need to make sure that what you make isn't as nice so that they do come back.
Yeah, that's part of my briefing as well, is don't make sure it doesn't fit too well.
Yeah, yeah, exactly. On the fifth reline as bits are flaking off or whatever.
Yeah, exactly.
But for sure.
So then, go on.
No, I was going to say, because that's actually, because timing of these things is important. But we sort of had a timeline. Should we go back to that timeline, or that timeline thought process?
Yeah. So the timeline said you're going to assess the case itself. You're then going to make your pros as if there isn't anything going to be there, no implants there. So you're making your best set of dentures. You've then planned it, as you've said there. And then you're going to do guided surgery, because you've already alluded to wanting, parallel implant placement. So you've got minimum sort of torquing forces and wear of those, those attachments, because that's, you're going to have a patient coming in every year with them getting loose again and changing it over. And there's obviously the cost involved. What do you find in terms of those? Because it's, what do they say, 40 degrees? Is that what they say they can do up to now?
Yeah, because each one probably has 20 degree as a ballpark, but you can get more now. I think you can get up to 70, because you can get an angled abutment, an angled locator, and then have an extended range on top of it.
But then you've got three.
But then you're all over the shop. Yeah, exactly. Yeah. You're all over the shop at that point. So I think you want to try and avoid that. Do you know what's interesting is people always think, or you sort of get, it is inferred that lower implant overdenture surgical cases are straightforward or more straightforward. And I actually think they're some of the most difficult, because you often have a knife edge ridge. So let's say you've planned it and you've got your two types of planning. You've got either fully digital, fully guided, maybe some digital implant placement, but analog guided. And then obviously we're saying you want to try and avoid total freehand, but eyeballing it. But, you know, most basic is going to be your DPT. And I came from, you know, the era of, you know, when I started doing implant work 10 years ago, it was a DPT with ball bearings in and your prosthesis that you just went from. And do you know what? That's fine. And I definitely wouldn't change that, because I think, you know, with those experiences, all of these newer technologies can only help you get better, and vice versa. You can always go back to that if you had to. But would I say that that's what you should do? No, I definitely don't think that's what you should do. You should be looking to make the most of the technologies that we have available to us, with the minimum being really a CBCT. And I'm a total convert to digital planning, because having done it for, I mean, I've only really been using digital for the last couple of years with regard to the actual planning process. But even taking your measurements, it's just so much more straightforward. And it helps you understand what you are likely to experience in the case, because you just put so much more thought process behind it. But you will often experience knife edge ridges, and you have to be confident at ridge reduction, because, you know, when you think about your implant placement itself, you want more than 1.5 mils of buccal bone, and lingual bone, ideally, which means you have to have a really quite significant ridge width. So you have to be quite confident with ridge reduction to get that. If you're doing grafting procedures, it's a one wall defect. So you need to think really carefully about skill sets for grafting. And that's why ridge reduction actually is a cheat, because essentially you're trying to avoid the need to do additional grafting and leaving things a little bit high. And also, you know, if you're looking for space, ridge reduction again gives you the ability to maybe think about a bar, when if you did no ridge reduction, so I think, oh, well, I'll just pop them in a little bit superficial, then you're on for bone loss and locators. The other thing is soft tissue management. I think, you know, we've seen so many of these patients who've had, you know, atrophied ridges for years. They've got a tiny little strip of keratinized tissue across the ridge itself, and even with your most careful split technique and maybe you know, a little H flap or something or other trying to put the tissue in, it's often that you'll find that there's no keratinized mucosa in that area, and that's when you need to start thinking about soft tissue grafting for patient comfort, trying to reduce the amount of plaque buildup. So, you know, there's lots of little complexities to these cases that actually you know, only with experience do you build up. And another one is the size of the incision. So just going back to that picture from before, you know, you can see the mental nerve in this case is right on the top of the ridge. So actually, again, you need to make sure your prosthesis is in the right place, because you need to think, well, do I want to actively go looking for it? Or am I so confident in my prosthesis that, again, I actually know where to avoid it? And generally, I go looking for things if I'm in any way in any doubt. And you might go slightly lingually so that you can fold. And one of the best bits of advice I ever got from my MaxVax rotation was work on a broad plane. So any type of surgery you're doing, you really want to, you know, something big heals the same as something small, but actually you'll damage the tissues less, because you'll be retracting less hard. You'll have much better visibility. You'll have much better tissue control. And you won't be nervous, and you can work from either side coming in, and the tissues just peel away, and you're just in control. And then you know that you haven't hit something, you know you haven't damaged it, rather than suturing up and going, I'm going to phone them in 6 hours and I really hope things are okay. You know, who needs that in their life? Just go looking for it. And, you know, that's all part of the skill set. And
so would you say the majority of your surgery now would you say you're all guided now?
Oh, it's a mixture. I digitally plan every case without fail. And I try and avoid brain guided if I can, because all of the evidence shows that even, you know, really experienced surgeons, generally everybody does better with a static guide, some form of static guide. And most of my static guides are a pilot drill, so either the 2.2 or the 2.8 to give me a little bit of flexibility, but it depends on the system that you're using. But I'm a big fan of that. Okay, if you're doing full arch edentulous, then you're thinking about bone pins, but sometimes I've had success with soft tissue that you sit in the right place and you can mark up and go from there, which is still more accurate generally than if you were just making something up.
We just had a question pop up from Andrina.
Yes, she's one of my osteology friends. Yes, hey, how are you doing? Let's see what she said.
Great skills with the laptop.
Yes, I think she's
clearly give us such great confidence in your IT skills.
I know.
So she's asking then, how many
implants
are you recommending for OVD in the upper and lower jaw when you plan your prosthetically driven guided implant placements?
So, do you know what, Andrina, that leads us quite nicely onto the next thing, because if you have 2 implants and an overdenture, I think something that we talked about briefly is that you have to warn patients it's going to rock. Yeah. So they, in their head, have this idea that you're about to create something that's like fixed teeth, and it's not. The only way you're going to achieve that, or do at least a better job, is by having 3 implants, whether they're splinted with a bar or not splinted as locators. Because if you can put 2 implants in the canine and 1 in a central position, okay, again, you need to make sure the position's spot on, because you don't want something bulking things out too much at the front or too far in. But I definitely think that if you can go for 3 implants, you will reduce the rock that patients experience, because it's when they come back and they go, so you put those implants in, but I can still lift it with my tongue at the back. And you go, yeah, I did mention that to you, but you have to really make sure they're well consented. So I would say the ideal, so the most basic for, to meet the York consensus and McGill consensus is 2, obviously, for an implant retained overdenture. 3 definitely wins from a strategic functional perspective for reducing rock, and 3 will give you, if you've got a bar, obviously it reduces it eliminates the cantilever force, because you have to be really careful if you're putting a bar in. If it goes straight across the front, is that encroaching on tongue space? If it's got a curvature, if you've put the implants too far back but you want a bar and you're going round the arch, then you're creating a cantilever and you're torquing your implants. And most of the time it's going to be a reduced diameter implant. So that's could be an issue. You might experience implant fracture. It depends what's against it. If you've got a full set of fixed teeth against it, if you've got a full arch fixed implant prosthesis with no proprioception, well, that could be an issue. Somebody's more likely to torque it even more. If they're off axis and you've got a straight bar, well, then you've got more of a rotation force. So you really want it perpendicular if you possibly can. So you need to make sure that they're not so far back. Again, it's arch form, isn't it? It depends on that arch. If you stick 2 canines here on a fairly flat arch form, actually it's still going to be a straight line. But if you've got a fairly narrow arch, pronounced curvature, 2 canines might be in the middle of the tongue space. So I think 3 is the ideal. And then obviously as soon as you head into 4 territory, you're thinking maybe about a fixed prosthesis. Well, you would be thinking about a fixed prosthesis ideally. And there's no evidence to show that 4 or 5 and more does better than 4, essentially.
And where are you on mini implants? Because some people think that's going to be the get out of jail free card with dentures.
Yeah.
I can do some mini implants. What do you think on those?
So I think a mini implant, I actually have no experience with mini implants, but mini implants have crossed my mind recently with some really complicated cases that I have thought about taking out teeth, doing ridge preservation before going in to do, and this is specifically around a large case in a young patient who has she's got a failing dentition for lots of reasons, but a really high smile line. But she has an uneven profile. So I couldn't do an FP1 because I'm going to have pink aesthetic. I'm going to have pink aesthetics on there somewhere. So I'm going to struggle with the transition. But to reduce everything to have an FP3, there's a lot to reduce. And in a young patient, in the back of my mind, you're thinking, right, when this fails in 10 years, 20 years, and, you know, how many cycles of treatment will she go through? And what will be left after each stage of failure? So I'm trying to forecast pretty much 60 years ahead, which is obviously impossible, but that's the sort of thing that you're thinking about. And so for somebody like that, early implant failure from doing a really invasive procedure where you're taking out teeth, immediate placement, immediate load, maybe thinking about immediate load, you're always trying to reduce your risk, but failure could be catastrophic for someone like that.
Mm-hmm. So you're still thinking of the restorative cycle in the same way that you think about it with teeth and saying, you know, filling and the crown, the root, you're still thinking that with implants, aren't you?
Absolutely. Yeah. You absolutely have to. You have to think about the age of the patient, how many implant or any form of restorative cycle. So I quite like the idea of mini implants for a case like that, because then you could think about doing, you know, ridge preservation, using mini implants in between. But then, you know, where does that stack up with cost? You know, are mini implants, you know, I mean, for me, that I'd be using them as a transitional prosthesis. But do you know what? In a last resort, maybe they could be effective. You know,
and
I mean, they've got the same surface.
People on that experience in implants, can you just go through FP1 and FP3, and then they're not a type of mask, yeah?
Yeah, exactly. You can get an FP2. So FP1 is a prosthesis, is a fixed prosthesis that is basically like teeth, and it's essentially gum fit. Whereas an FP3 is a fixed prosthesis that has a full set of pink acrylic or pink ceramic. So the transition line is hidden. You know, the transition between the prosthesis and the patient's tissues is hidden. So that's your classic all-on-4 style treatment.
Mm-hmm. And you need good patient compliance with that.
You need good patient compliance with everything. I mean, absolutely anything. And you need to make sure that every patient is on board with a regime that they're going to continue with afterwards, a care program. You know, you don't really want to treat strangers with all these things. You need to have at least a few appointments to try and get a feel for a patient. You know, if they've been your own patient for a long time, that's perfect. Referral practices are obviously more challenging because, you know, the patient's referred to you, they see you for 1 or 2 appointments and you can be jumping in. So I'm very risk averse. I generally try and break stages down if I possibly can. And as a result of that, actually, I have, you know, touch wood, very few emergencies, because I hand my number out to patients, but actually patients very rarely call you. And I just think that's de-risking. I think that's a de-risking strategy.
Mm-hmm. So then if we're talking fixed stuff as well, is cost the only factor? Are there certain cases where you'd say if money was no object, definitely bridge, definitely, you know, denture, but if you're saying all on 4, blah, 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 you know, like, is there anything other than cost? I know,
yeah, totally.
I saw a case that Finley did with, it's all positioning of the teeth, and he's had to put the teeth massively beyond the ridge to get the lip support that you need, and things like that. You need to have a denture for that.
Absolutely.
How do you go through that kind of thing? And are there other situations like that?
Well, I mean, you know, you've hit the nail on the head, because, you know, your prosthesis, if somebody comes in and they've got a massive chunk of plastic, you know that you're going to need something to give them the lip support that they need moving forwards. And then you have to have that conversation, and you have to say, well, is it even possible to graft out this far to achieve what needs to be achieved? Again, you have to be really thoughtful of where the ridge is, the residual ridge, versus where the teeth need to be, because you're again creating a cantilever, and sticking a whopping bar on somebody could again encroach on their speaking space or their tongue space. So you have to think, well, how much space do I have? And this is where digital comes in again, because, you know, you can design your ideal prosthesis, you can scan it, then the lab can take an index, or they don't even need to, you know, you don't even need to scan it. You have a putty index on the cast itself, and then you can look at that prosthetic space and you can start trying to measure it. But the nice thing about digital is you can do that subtraction. So you can say, right, where's the ridge? Where do I want the implants? How do I superimpose this? Where will things go?
Adrena's on you again.
She's on it. No, so what about multi-unit abutments? Yeah, Do you know, I think that's cost. I think these things, what do you mean, Andrea? As in, I'm just trying to think how, so what, do you know what one thing that was great about John's topic the other night, and is a real bugbear of mine, is how systems are making, how are we doing for time, by the way?
We've got about 20 minutes.
Okay, cool.
Flying through.
I worry a lot that companies are creating products for us that disrespect or disregard biological principles. So if you have a multi-unit, then at least that is a conical connection. You still have platform switch. You have a tiny micro gap that loads better, less, there's less micro movement, less bugs generally in that zone. And therefore, hopefully less bone loss. Whereas we are getting bars, for example, that will be milled or can be machined that sit straight on top of the implant. And essentially they're using the implant shoulder that's designed for the platform switch as the base upon which they sit, which means that the screw takes all of the load. They have really poor resistance to being twisted off. Then the micro gaps at bone level. I was just trying to see, MUA do not. Okay, so the one time, although I'm not sure I've seen any sort of a huge amount of evidence, but the one, one time abutment, you put it on, it's done, you forget about it. Yeah, okay, I mean, that makes sense. The thing that I struggle with slightly about the one time connection is that you stick it on, and it's during surgery and there's blood everywhere and you can't clean it effectively, and then it's always a bit grotty. I'd rather change it down the line, give it a really good clean out, and then pop something on, making sure that there's no, or minimizing the chance of there being some gunk down there. I'm not, I think people have to be very careful about what we're being sold with regard to what can be done technologically versus what we should be doing biologically. But obviously there's a significant cost saving, because you might find that, your multi-units are 180 quid each time. So actually you've just suddenly stuck 600 quid on a treatment plan. Mm-hmm. I was thinking, do you know what, we should have a quick look at the locator pickups, because that's what people wanted to see, wasn't it? Before we run out,
I was just
let's do a run through.
Just going to say.
Let me grab my, I had got it. Okay, technophobe, right. Let's see. Okay, so this was a case that I saw, and we're going to go back to this one, because this was, there's a nice case to sum up everything at the end. But if those are your and there's the locator wear, you can just see some of the wear. So if you don't have reasonably parallel implants, that's the sort of thing that you can see over time, and you're switching things out. Mm-hmm. And it's more pronounced for the greater divergency. Is that even a word? How divergent they are. I was meant to be on holiday today. Okay, right. So what you've got your locators. Let's say you've got your locators, okay? Mm-hmm. And these are the little housings that sit on top of them. They just snap in. They come with little black inserts, and the black inserts don't have a lot of I was just reading some of the questions, and everybody seems to be agreeing. Yeah, exactly.
If anyone's got any other questions, pop them in there and we'll come to them at the end. But we're just going to cover this quickly.
Cool, let's do it. So you've got the little nylon inserts, and they're just really simple, not overly engaging little inserts that allow you to pop it on and pop off. Right, yeah, exactly. What you will notice is that you have really quite delicate little channels that go around. So they're the retention devices. And I really like Quick Up, which is one of the materials that you can use to bond on. But I make sure that I'm syringing in and around here, as well as onto the inside surface of the denture. So you're really picking up and going into that fit, into that retention groove. Then what you do is you hollow out the inside of your prosthesis. You have to be so careful with this stage, because it's really easy to not hollow it out enough. To have something that's engaging, so your denture isn't sitting. So you need to know the feel of what your denture feels like, and even, look at the occlusion, check all of that. So you can also get a fit checker, a silicon fit checker. that you can inject and squirt around to make sure that it's not engaging or touching. It's like a blue silicone. The thing
spray.
I would, yeah, but it's like a little, it comes with the quick up kit. So some kits come with it and it's basically a space checker. What I would say here as well is the thing that everybody's terrified about, and this is obviously for a direct chairside pickup, you can get little white donuts that go around this as well. So I will often put on the extra, the washers, exactly, the little silicone washers. So you pack them down to make sure that they're touching the tissue so that you're definitely not getting any acrylic locking in and underneath. That's never happened to me, but I am so careful with packing enough washers in to make sure that you're good to go. So then also, you can punch your little holes. Some people punch holes, some people don't punch holes. The benefits of punching holes is obviously it vents it. You get less scooshing out underneath, but it does mean that you have to obviously polish it up, and some patients might not be overly impressed that you've just punched holes in their brand new denture, so that's a consent perspective. But actually I find that the wear of it is pretty good over time. You don't get too much water absorption and staining if you do a decent job of the bonding. But yeah, I don't think it's too much of an issue. Fill it all up. Like I said, I filled those, but I've also put the quick up around the housings themselves. And then in it goes, squirts out through the inside, and then you wait. What I like about quick up is it's got a really defined snap set, which means that at least you're not, it takes a little while for it set, but you've got enough working time to make sure that you get things where you need them. And then it's gone, rather than going, oh, is it doughy? Has it set? Maybe it's set. And then you take it out and you've got distortion. At this point, you might get a little bit of acrylic overflow, and this is where the washers. So if you don't have the washers, that's probably what you're going to see, a little bit of acrylic flowing in and around. And if things are really snug, that's the sort of thing that might catch. So the washers will prevent that. You then and that's on the outside, you then just need to drill that away, and then you can just get a probe underneath and just flick the little washer out, tidy it all up, get rid of all of the flash, and those are the housings. And then you can insert the little inserts themselves, and you just choose the ones that you need for your patient. You can also get other types of housing. So if you don't have enough horizontal space for a locator, you can start thinking about ball abutments, because they're taller, so you need to have more vertical height, but you don't need to have as much width. So that might be a cheat. This is something that I really like. This was for a patient of mine who, from a cost-effective perspective, she needed, we went down the route of a cobalt chrome. This is more of it is an equipoise design, but we went with a single implant in the premolar side because she'd had an extraction there previously. And actually, when you've got a canine, and it's always challenging to have an aesthetic clasp in the aesthetic zone, or something that doesn't go up too high or is uncomfortable for a patient. So actually, with these equipoise designs, you can see how it's almost a mesial distal rather than a buccolingual position. But again, you need to have the right space, because width of the tooth, because as we all know, you need to have a clasp that's flexible enough, because otherwise it's too rigid and it doesn't work the way it's meant to work. But what's so nice about the little locator is actually it just gives retention in the zone where you're going to get that denture dropping down. So that can be a really cost-effective functional solution for patients. Let's see what else.
It's almost like a sort of IKEA Meccano sort of modular approach, isn't it? You can just add a little bit here, add a bit there. And that's partly what we say with the lower cases. You know, you put your McGill 2 in the canines, and you say, well, you start with that. That'll make the denture a bit more stable, and then maybe you want to move up, and then you could look at 4, and we can we can retrofit those in as well, and then you might want to then go all the way and upgrade it to. And if you've planned it all from the start with that, you can sort of build up to eventually a fixed prosthesis. Absolutely.
For every case, I'm always trying to think ahead to the ideal implant position if a patient's losing more teeth down the line, because I think it's just our duty of care to think about things like that. And this is another quite interesting little case, actually. This is a locator that was attached, that was soldered onto post. I did the prosthetic work. I didn't do the implant work. I love this and I hate it at the same time, because from a cost perspective, failure point, you're thinking, right, you need to have such a good route that you have a decent ferrule on, you have to have it so optimized to be able to consider a treatment plan like this, because otherwise, you know, why are you bothering? You're basically you're cooking in failure at probably a fairly early stage, and no patient's going to thank you for that. And this is a cracker that I saw a few years ago. Again, it just comes down to space. So this patient had dental treatment abroad, and her problem was pain. You almost can't see it, but right here at the back, she had so much dental alveolar compensation that she had this tooth pressing up against the tuberosity at the back. And there was absolutely no space for this attachment here. So I ended up having to increase the vertical and use composites on the plate. So basically platal composite veneers to increase the vertical. But she didn't want to have a new lower cobalt chrome. She wanted me to reuse the frame that she had. And I said, there is one massive issue with this. And it is that I cannot control your dental alveolar compensation. Because it was just literally a clasp. It was a clasp that was just wrapping around the tooth. Oh, hang on. It was wrapping around the tooth. Not very good with the lag. But didn't have any form of occlusal rest. And so I just thought, I literally said, in 2 years, this will have done exactly the same thing. And it did, unfortunately. Did exactly the same thing. Opened her up, dental alveolar compensation, everything closed in. 2 years later, she came back with the same problem. It's such and again, it's consent. It's consent. No, exactly.
We had a couple of questions that come up there.
Yes.
We've got about 10 minutes, so let's just go through those. So where did we get to? So yeah, Mike says, so locators do seem to wear a lot. I get the feeling that ridge resorption post-implant placement down the line and the denture needs relining before the wear and movement becomes an issue. So is that part of it? You know, keeping tabs on it. Are these still fitting well? You know, if the denture needs relining, then obviously there's going to be more rotation around those, making those locators work harder. So is that something, you know, annual reviews and things like that?
Yeah, I think that's just making sure that you've considered the patient. They know that that's part of the long-term upkeep, because, as you say, a removable prosthesis denture, let's say, lasts for 5 years. But you're going to have resorption during that time, and it just depends on the amount that the patient tolerates it, because some patients tolerate a lot. Some patients come back and say, oh, it's loose, and you can barely get it out. And some patients go, oh, I'm fine. And it's literally, it's not even retentive anymore. And definitely the more slop, you're going to get more wear for sure. That has to be the case. Yes. So there's new materials. There's different materials now. I think Zest are wise to the fact that the classic gold locator wears more, and there are newer inserts. So you can get different nylon inserts that are more resistant than the standard Zest anchors. And you can also get, Zest have released a more wear-resistant locator that has a slightly different attachment on the top. So there are alternatives out there.
Mike then said, do you do the pickup at the fit, or is Charlotte still or prefers to leave for a week or so to let them settle? So that's sort of what we're talking about initially, is almost actually the dentures are being made, or at least the way I'm doing it, the dentures are being made quite a way in advance, and even sort of you're having them in for a couple of months to check you're happy with them, and then they're having the implants done, and then they're osseointegrating for a few months. So in our timeline, they've had the dentures for 5 or 6 months by that point. What do you do with that? Are you doing certain ones and then fitting straight off?
I usually fit, but I suppose, because the flip side to that is, what are you doing? You're hollow. The implants go in, I would wait for them to integrate. I would then put healing abutments on, and then I would wait for the soft tissue to take a final form. So I like to make sure that I've chosen the right locator for the tissue height, so a mature tissue height. So I'll wait for that to happen. At that point, when you've got your final prosthesis, and you had, let's say you'd fitted I suppose you could leave the healing abutments in, hollow out the prosthesis, then they come back a couple of weeks later once they're happy, you hollow it out a bit more. I suppose I want to minimize the contamination of the surface that I'm cutting out. So I suppose if you cut out a fresh surface and then you're working from there, I think that would be absolutely fine. I think there's definitely the question between a direct and indirect pickup. So at the impression stage, I think you need to be making sure that you're really, I have ended up doing more direct pickups than I have, and I'd be interested to see what you guys are doing. because I've just been stung enough times with indirect pickups that I click it in, it's not quite what I was expecting. And there's a fractional discrepancy. And actually, the number that's happened enough times that I now almost always prefer to do a direct pickup, because you've just got the feel, you can just see what's happening, you can feel it, you know what's going on. But obviously that's a longer appointment, it's more technique sensitive, it's harder work.
Yeah.
What do you guys do?
Nick wants to do it chairside.
Yeah.
Always. Yeah, absolutely. Smile Dental was just asked then, how long do you say the dentures with locators last? So this is, and then the implants themselves. So I guess we've got 4 or 5 minutes, so let's just talk about that and consenting. And then this is important, even if you're not the actual, prosthodontist or the implant placer, you're actually maybe referring on. It's a good idea to have at least a rough idea of this. So, are you saying you need to change your the locator attachments every year, or what are you saying to those patients like that?
Yes, probably along those lines. I definitely bake it into the consent form itself, so the written consent. Patients know that every single part of any form of dentistry I provide will fail at some point, and that they will need to be replaced to cost themselves. From an implant perspective, obviously implant companies guarantee their implants generally for the lifetime, but I say there will be a cost. And I say that implants have been around for 50 years. The current set have been around for 10 years and a bit more, but they're changing designs. We know that implants work, but I can't tell you this is going to last for your lifetime. It may wear out and need replacing at some point. Anything that goes on top of it, so if it's a crown, the Peterson systematic reviews, generally I say 80% survival at 10 years. Something like a locator, if you say a denture is going to last for 5 years on average, then it's probably an entirely reasonable statistic to say that the things that the denture attaches to will have to be replaced once or twice in that lifetime. So let's say it gets replaced at 2.5 years. I think that's a pretty fair statistic. Obviously, you need to tailor that depending on what's happened. So if you're sitting there looking at 2 really divergent implants, you know that those locators are going to wear at a rate of knots, at which point you need to start thinking, well, maybe I should be putting a ball abutment on it and not a locator. Maybe I should be thinking about putting a bar on it so that I can level this off. So I think you would have to tailor things to what you found clinically at the end. But I have sort of general stats, and then I would modify things as required.
Perfect. It doesn't look like we've got any less questions. So I thought we'd just close with a little plug, because I know you love talking about ITI Future Stars.
Yes, good call.
So
good call. Yeah, it is
minutes,
totally. Okay, magic. So Future Stars. So the ITI, ITI is looking for people who are going to be the presenters of the future. If you have any case, any research, just things that you love, things you're passionate about, if you go onto the ITI UK and Ireland Congress website, so we've got the big the Congress itself in our Young ITI Day is the last day of September, and then October. It's one of the few events that's still happening because we managed to hold our nerve, well, unless something changes drastically, but held their nerve, so it looks like it's going ahead. If you go to that website and you go to the Future Stars tab, you'll find all of the instructions. But basically, it's uploading a short 60-second video of yourself, what you're going to talk about, some slides, a PDF version to put up there. And there's going to be 10 posts that are going to get put up to be voted on. Mm-hmm. And then the best 3 will get to present on the actual day of the main Congress. And the best future star, or the future star, will have a certificate presented to them by Danny Boozer. So, I mean, you can't ask more than that. Well, it doesn't get better than that. So, we would love people to apply for it. So please don't hold back. If you love something, it always comes across. So just go for it.
And I need to work on mine. Owen's twisting my arm behind the scenes.
Tell me about it.
One last question, just from Smile Dental. What would you say, if you don't mind asking, average cost of a 2 locator denture? Sort of ballpark.
Let's say, well, what's the average price of an implant? Probably 1,200. So let's say 2, 4. Then the locators that go on top of that are, let's just say, 150 each, so that's 300. And then your denture on top of that. So your lowest price is probably 3.5, but that doesn't build in any failure. So I would say 4. You need to start thinking about what happens if something doesn't work, if I need to replace it, and how do I absorb those costs.
Perfect. There we go. Which I think we're going to get kicked off any second. So, Matt,
cool.
Cheers.
Okay. It's been a pleasure. Yeah, pleasure, Reeves. Take care of yourself. I'll
Cheers,
catch you
buddy.
soon. Cheers, everyone. Hope everybody enjoyed it. Cheers, guys. Bye.